Just tell you the background of this workshop is one of the most critical aspect of acute care is having a flawless procedure, and we do agree that errors in emergency medicine or errors in emergency care kills more patient than other diseases. And even in the US, almost more than 1 lakh deaths they do occur due to medical errors, and that is underreported. In our country, you see that there is no quantification or burden of error being quantified in the healthcare sector, whether it is prescription error, whether it is procedural error, we do not quantify, or neither we bring it to the notice. We do not bring it to the notice because of punitive action, because of fear, and ultimately the patient is going to suffer. So, in the quest of patient safety, it is so important that without a blame game, they say that no blame culture or a culture of patient safety should be imbibed by all emergency care physicians or acute care physicians. In a high stake environment like acute care, whether it is ICU or in the emergency department, it is a high stake environment. You may say, I am bound to do mistakes. Yes, we are human, and with the famous statement of what is called as the to err is human. You know that where it came from? Institution of Medicine report 2000, the famous document to say to err is human. But how much to err? Till you get killed by the patient get killed, you are causing a fatal error, intentional and unintentional. So, to address those situations, we need to cut down on error. But how do we curtail? There are 3 types of error which can occur. One is due to system error. You do not have machinery to use the machines or equipments to treat a patient. Number 2, deficiency in learning. Deficiency in learning is one of the major errors. Deficiency in learning or deficiency in your expertise leads to human errors, and it is unintentional. You see that you want to do a procedure, but if you are not proficient enough, then what do you do? It causes a serious risk again. So, that is why this course is apt, and you see most of the procedures what you are going to learn in emergency care is usually we have done till blind way. We have added ultrasound to make it as a visual resuscitation. Number 1, it enhances, it changes the practice of emergency care, like how you saved a patient in the emergency department when you did a visual resuscitation in that patient which you presented in CCR, and that really addressed the patient safety issue. And that was the crux, because it empowered you to take that decision to send him to the definitive care immediately. One was the power of ultrasound. Second, to give more realism or simulation, what can be better than a cadaver, where you are doing the procedure, the same whole procedure in a human body, near realism, how the tissue looks and how you can do the whole procedure in a fearless manner is important. So, that is why this cadaveric workshop has been planned, and it is going to be there for especially for the resident training in acute care. So, what we have done for this is we picked up common procedures which are done in the emergency department, which we have chosen as a menu, like airway procedures. You must have seen needle and surgical crico, we are going to do. It will be empowered by ultrasound. Simultaneously, there is a session. So, there will be a short lecture series that Dr. Prakash said. Then we picked up pericardiocentesis, pick up a chest tube, where again there will be simultaneous 3D simulation. I will tell you how it will go about. Then there is a procedure of common blocks, especially in the ER related to trauma patient, to address the limb emergencies. The commonest block, upper limb block, is brachial plexus we are going to do, and anterior sciatic nerve block for lower limb blocks. Below the knee, if you are doing a procedure in Steinman pin, you require to give an anti-sciatic block. And fourth most component is the vascular access. In vascular access, we are going to do, because in cadaver the vessels may be collapsed. So, what we have got it a beautiful phantom for you, which is again a simulated phantom, and you can do ultrasound guided vascular access procedure. And intraosseous, you are going to practice in the cadaver. You will be taught hand-eye coordination, which is critical for any procedure. You can do live with the patient, in the cadaver, and also in the phantom, right, hand-eye coordination. So, this is what we are going to the format of this thing. So, in the first thing we are going to know, they are ready with the pre-test. So, we will give you the first format, we will do or give you a pre-test. Okay. After we do few short lecture series of 15 minutes, okay, then what we are going to do is, after having a cup of tea, then we will do what is called as, the faculty will train you in detail about the procedures with the cadavers, along with first there will be demo by the teacher with the master bed there, and it will be simulated. So, I suppose you are doing chest tubes, there are 4 stations you will be there. Station 1, you will have needle and surgical crico, which will be empowered with the ultrasound. Second group, you will have chest tube and pericardiocentesis. Obviously, this is a cadaver which heart has been removed, but what we are going to do is the 3D simulation, where you will see live on a simulator how you will get a pleural effusion here, and how do you get a tamponade, and what is the methodology of insertion. Then you practice in the cadaver. It will be simulated simultaneously. So, you will get a better picture. Then the third station, you will going to have a vascular access in intraosseous, okay, and the fourth one remaining is the blocks. In blocks, you will be again you can practice by the hand eye coordination on the live cadaver itself. With the phantom, you will have phantom as well as cadaver. So, you will get double, and simultaneously there is a during the 3D simulation we will teach you the new integration which we have done is the zygote body. In zygote body, you will see the 3D anat of the particular structure you are looking at. The master trainer is going to teach you whenever you are taking particular needle or surgical in your intense program between 11:30 to 1 o'clock. So, he will also simultaneously first teach you the anat and its relation to the nearby vessels with the zygote body. There is a 3D anat with views from all the sides. Okay. Then he will teach you on the cadaver with ultrasound. Is that okay? So, you will get a much better framework of mind, in integration of multi-model teaching models, right. Cadaver, ultrasound, as well as the 3D simulation through zygote.